Hello, everyone, and welcome to the New York Hypermobility Collective. My name is Dr. Melanie Carminati. I'm a physical therapist. We're joined this evening with Dr. Jason Siefferman. Our topic for this evening is gynecological and pelvic health considerations. This is a third webinar of our series of webinars. We'll be starting with Dr. Siefferman.
Hello, everybody. So I'm going to give a brief overview of pelvic pain as it's associated with hypermobility. And of course, this is a massive topic, and I am not going to do a textbook's worth of information in 20 minutes. So as we dig into this, what is the pelvis? So we draw our boundaries here. So with the ring of the pelvis, there's the bony ring. There's the spine, the base of the spine. There's all the internal organs. There are the hips, all the muscles, tendon, ligaments, and joints that surround it, the nerves that go through this area. We think about the bowel, bladder, reproductive organs, and blood vessels. Often we forget to think about the blood vessels, but they play a role with hypermobility and pelvic pain. So all of these parts are considered. When we think about the pains that can be caused by hypermobility, generally, these are the structures we're thinking about. So the spine, of course, hypermobility in the spine can wear and tear the disc, the joints, the surrounding structures. Things like transitional vertebra are more frequently found in those with hypermobility, which can also be pain generators. The pelvic ring, which includes the two ilia and the sacrum. So we have the sacroiliac joint and the pubic symphysis as the points of contact. Instability of this ring doesn't just cause pain in those joints, but it allows jostling, tension, movement of anything inside the pelvis, because that pelvic ring is really responsible for much of the stability of that pelvic structure. The hips, which although they're outside the bony ring of the pelvis, they do play into the pelvis, and the hip muscles go inside the pelvis, and the nerves pass along through these areas, so they can all be involved. Hernias. And hernias can involve a few different areas, just above the pelvis where the inguinal hernias are, or femoral hernias, and then obturator hernias. Lots of opportunity for hernias to cause pain. Vascular, like pelvic congestion or May-Thurner, nutcracker syndrome, things like that, occur more frequently with hypermobility. And of course, issues with the internal organs. So rectocele, prolapse, things like that, chronic constipation. Generally, any of these structures can cause pain, primarily due to hypermobility. Then once we identify primary pain, we want to think about secondary pain. And secondary pain arising from the instability can come about ultimately from impaired mechanics. Obviously, if something is not moving properly, you're not able to use it the way it's ideally, designed or evolved to be used. And as a result, you'll misuse it. And then there's often compensatory balances that occur in other areas. So whether the structure that's being misused becomes a source of pain, or a structure that ends up compensating and taking stress because the structure that's not moving properly is not taking the stress that it's meant to take, impaired mechanics lead to pain. Labral tears on the hips. So the hip, if it's hypermobile, if the ball is not stable in the socket, it will tug and tear and pull at the labrum, or it'll pinch the labrum, and those will tear and degenerate. Disc herniations in the low back, joint overuse, which I kind of mentioned in the impaired mechanics. But when we think of joint overuse and hypermobility, it's not like the entire joint is equally overused. It's more that a portion of the joint that gravity pulls the joint into, or the mechanics of use pull the joint into, it tends to be one part of the end range of the joint that gets repetitively overused. And so it degenerates more quickly because the forces are not spread across the joint so evenly. It's easier to think about this in the knee, because the knee, if there's misalignment between the upper leg and the lower leg, you see the leg's not straight, it's bent at the knee to the side, like varus or valgus deformity, you'll asymmetrically wear the medial or the lateral aspect of the joint. Muscle guarding, of course, this results from any pain, any instability, any potential pain, any impaired mechanics causing compensatory motion will lead to muscle guarding. And of course, with chronic muscle guarding, you're overusing those muscles. Where those muscles attached to the bone, called the iphysis, can become overused. The bone can react to that. And the tendon in between can be strained and torn and overused as well. And then, of course, neural tension. So if something is stretching, if something is moving, if it pulls on a nerve, if there's a nerve that goes through that structure, whether it's a hernia or the sacrospinous ligament or the obturator foramen where there's a hernia, like you can have tension on nerves. And then, of course, nerve entrapment, just associated with the hypermobility as well. And aside from primary and secondary pains, we also have to think about sensitization. And when we say sensitization, we really mean the nervous system has learned to be hyperreactive. I say like the nervous system holds a grudge. So this can happen if there's severe chronic nerve pain or visceral pain from one cause, or it can happen if there are multiple simultaneous sites of pain in the same region. And generally, that's more common. So you may have a little bit of hip impingement, you may have an inguinal hernia, and you may be okay with both of these things, but then suddenly you have endometriosis, or you have chronic constipation, or you have a UTI, and then the summation of pain from these three things going to the same area of the spinal cord triggers the nervous system to become sensitized. And what that means is the nervous system just pays more attention to that area. And normal sensations start to become interpreted as painful, like light touch, pressure, things like that. So when we're assessing and thinking about pain related to hypermobility, we're thinking about the primary pain sites, we're thinking about secondary pains, and then we're thinking about sensitization in the nervous system. So we're going to dig into each one of these in a bit more depth. And I apologize, I'm going to rush through these pretty quickly because otherwise we will be here all night. So if you want to talk about anything later, I'm happy to chat later. We can talk in the question and answer session. Let me know. I'm happy to be of service. So when we think of hypermobility and the spine, we think first of instability. So is there spondylolisthesis? And this is where one bone slides relative to the other. It can slide to the front, it can slide to the back, or it can even slide side to side. There is the primary instability itself, and then there is the guarding response to the instability. And both of these things can be problematic. When the tissues are hypermobile, the discs are also hypermobile. The ligament that holds the disc in place is easily stretched as well, and more easily stretched. And especially if there's instability of the spinal segments above or below, then that can lead to wear and tear on the disc, herniation of the disc, and any issues with the disc. It's just more common to happen in those settings. Spinal nerve irritation also comes from disc herniation, comes from tension. When a disc herniates and then it heals, the nerve next to it will often get stuck to that disc. So there's a point of adhesion of that nerve. And then if there's any other stretch that occurs, it pulls on that adhesion point. That can be a source of pain. 1, 2, and 3 happen in non-EDS people as well. It just happens more commonly with EDS because the ligaments are responsible for holding all of these things together. Now, other things that do happen more commonly with hypermobility, transitional vertebra, that's what this picture is over on the right, where there's a Bertolotti. You can see the arrow pointing to this area of pseudo-articulation, where the lowest lumbar vertebra should be fused with the sacrum, or it should be separate. They shouldn't be rubbing, but that can definitely be a source of pain. So spinal instability, disc herniation, spinal nerve irritations, adhesions from those nerves, that happens in the normal population, even without EDS. It's more common with EDS, just because the ligaments that hold everything together are stretchy and they're easier to be injured. Transitional vertebra, such as the Bertolotti syndrome, which you see over here with the arrow, shows an area of pseudo-articulation. This happens in 36% of the population, doesn't always cause pain. It causes pain from rubbing. And of course, if there's more mobility in the area, there's more rubbing. If there's more rubbing, there's more pain. So we tend to see Bertolotti more often as a pain generator in people with underlying hypermobility. Spina bifida is what happens when the neural tube doesn't close perfectly when the fetus is being formed. The posterior elements at the base of the spine are not always fully intact. There can be neural related issues to this. Tethered cord happens often in association with Chiari, but basically the base of the spinal cord is tethered down and it doesn't allow it to move freely. So there can be a point of neural tension on the sacral roots, which can cause sacral pain, usually rectal pain, genital dysfunction. And then finally, Tarlov cysts, which is always a fun topic because They show up frequently on MRI, but they're so very rarely a source of pain. And there are surgeons who make it their livelihood of treating Tarlov cysts, but as I said, they're frequently present. They're rarely the actual source of pain, but it's easy enough to do diagnostic blocks and tease that out. Looking at the pelvic ring, starting at this image at the top, I sort of went through this ilium, sacrum, sacroiliac joints, pubic symphysis in the middle. With the pelvic ring, there are also some stabilizing structures that can be involved with pain. So the sacrospinous ligament, along with the sacrotuberous ligament, provides stability to the sacroiliac joint. If the sacroiliac joint is hypermobile, there will be extra tension on the sacrospinous ligament and the sacrotuberous ligament, which themselves can be painful just from the extra motion occurring, the extra stress on those structures. But separately from the direct ligament pain itself, the pudendal nerve also crosses over the sacrospinous ligament. So if there's tension on the sacrospinous ligament, it can put tension on the pudendal nerve. Hernia sites. So the next picture down, sorry, that shows you all of the different potential hernia sites that can occur in the front of the pelvis. There's a few, right? So when the tissues are lax, when they're more easily stretched, the opportunity for hernia is improved. And the most common ones we see, inguinal, femoral, and obturator. And these each affect the nerves that are going through those sites. Hernias cause pain in 3 different ways. Number 1, the nerve that goes through the site is often irritated by the herniated material, which is usually fat pushing through. So basically, each of these sites, it's a canal, it's a place, a tubing where the nerve goes through and some other structures go through. There's not meant to be anything else going through there, but fat from inside the abdomen can push into there and crowd out that space. And in crowding out that space, it can irritate that nerve, and that's probably the most common symptom. So inguinal canal will often cause pain down to the testicle in men, to labia in women. Femoral canal will go down the front of the thigh. Obturator foramen is inner thigh, and both the femoral and obturator, and even inguinal a little bit, can mimic hip pain. So it can be a little bit confusing because those nerves are irritated, the area becomes sensitized. So irritating the nerve is one way that hernias cause pain. Second is the material inside the hernia can be squeezed because it's compressed into that site. And that visceral fat also has sensation, and that usually goes through the sympathetic nervous system. So it's not completely uncommon for inguinal hernias to cause bladder sensitivity or frequent urination or pain like that. And then the final thing is the abdominal wall sort of reacts to this extra pressure, that extra stress, and contracts to tighten to try and keep things from going through, but yet it cannot effectively do that. So you end up getting abdominal wall pain in response to a lot of these hernias as well. Pubalgia. Pubalgia by itself basically means pain at the pubis. We use this as shorthand for a sports hernia. And a sports hernia is also not the best name for it because athletic pubalgia sports hernia is not always driven by athleticism or by athletic activity, although, if you're a runner, soccer player, anything like that, it can happen frequently. But essentially, this bottom right image, you see there are vectors of forces pulling up on the rectus abdominis and down from the adductor longus, and they both attach right at the pubic symphysis, right at the same place that the inguinal ligament attaches. And so these structures come together, and it's a common point of strain, and you can develop a sports hernia at that point. And then osteitis pubis is at the pubic symphysis, this bottom image. If there's extra rubbing of the pelvic ring, then you can have irritation, wear and tear at that pubic symphysis. All right, hips. Labral tears can be from chronic instability or trauma or both. And of course, you can also have hip impingement on top of this. We're not speaking about hip impingement because that's not a very specific hypermobility issue, although it can also happen in those with hypermobility. So labral tears can be just from the chronic instability, just from the hip bobbing around in the socket, pulling on the labrum, bumping the labrum, irritating labrum, or it can be from trauma with dislocation. And of course, the trauma will worsen the hypermobility. When there is pain or instability of the hip joint, there will naturally be forward rotation of the ilium. So there's going to be rotation at the sacroiliac joint, just to put more stability on top of the hip, just to cover the hip better, because the hip is anteriorly unstable, more so than posteriorly. So the ilium will rotate forward. often there's a bit of hip flexor activation to keep the hip a little bit flexed because that pushes the hip back in the socket. So a lot of people will complain about iliopsoas pain or iliopsoas bursitis, but it's not really that. It's really the hip. They're just feeling that muscle because it's being overused. On the posterior aspect is ischiofemoral impingement, and this can affect the sciatic and posterior femoral cutaneous nerve. And then also the athletic pubalgia, because the adductor longus is another stabilizing muscle of the hip. And if it's pulling at the pubis, that can trigger it as well. Guarding of the hip, I mentioned the iliopsoas in the front, the adductors in the front, the tensor fasciae lata, which will make the IT band tight. Not uncommon for hip hypermobility to cause knee pain radiating down. Piriformis in the back, which can put tension on the sciatic nerve and cause sciatica. Obturator internus can cause pudendal neuralgia by pulling on the pudendal nerve, or if it's enlarged, because that muscle is just chronically being overused, then it will actually occupy space. And this is where Botox can be helpful because it'll shrink that muscle so it doesn't take up as much space and push up against the pudendal nerve. And then, of course, bursitis, and lots of kinds of bursitis, lots of locations for bursitis, the iliopsoas, greater trochanter, ischium, which is really just from the muscles micromanaging the motion of the joint, right? So the core issue with hypermobility is that the ligaments in the joint capsule are loose. They do not do the job of holding the joint together, so the joint is loose. And the muscles then kick in to try to hold the joint together, but that's really not the primary job of these muscles. These muscles are really intended to control the motion of the joint, not stabilize the joint at this level. So when these muscles are constantly being used to stabilize the joint and micromanage the motion at every instant, you end up getting a bursitis, you get a tendinopathy. And if you see an MRI and there's like small tears of glute medius, glute minimus, tendinopathy, blah, 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 it's all from chronic guarding. And the hip is the primary source for that guarding, not those tendons, not the bursa. All right, hernias, I kind of went through a lot of this already, so I'll breeze through this. But when we think of hernias, generally pain with sitting, Valsalva, constipation, as I said before, it can mimic the hip, and it will frequently sensitize the nervous system. All right, vascular issues, pelvic congestion syndrome. If you haven't read about this, this is one here. It involves the ovarian veins. You get dilation there, you get backflow. Can be a significant source of pain that's difficult to pinpoint because each of these vascular issues, it's not like a hip or a hernia where people will come in and say, oh, it hurts here, or it hurts when I do this. It's really often a hurt all the time, and I can't really describe it, and I don't really know where it's coming from, but everything's just so sensitive. And sometimes patients don't even complain of it. They don't even recognize that they're sensitized, but they are. And then this is something I pick up on exam, or if we do some procedure and it's tremendously uncomfortable, sometimes we'll recognize that. And then that's when we start to look for these deeper things. Anytime we recognize sensitization as a process, we want to understand why it's happening, what's driving it. And so these are on the list of things we consider. And then, of course, internal organs, the bowel, constipation, prolapse. And then I'm going to let Dr. Friedman talk about the reproductive organs. What is our approach to this? As a pain doctor, I'm looking to identify the primary source of pain. What is the actual structure at the core that's causing all these trickle-down effects? And of course, it's usually the trickle-down effects that bring people in. It's the bursitis or the pudendal neuralgia or the pelvic floor. It's something downstream that's bringing people in, and I have to do the work at figuring out what the primary issues are. And as I said earlier, with the pelvis, by the time I'm seeing people, it's not usually just a singular issue. It's usually multiple issues, because usually single issues will get better and people will be fine. It's when things start to summate and they aren't addressed and they aren't treated, that's when they really start to become serious pain issues. And that's when the sensitization happens, and we really just have to reverse engineer that entire situation. So the goals: identify the reason for the pain. And when we're doing this, we're considering all of these things. So is it just hypermobility? Was there some specific injury? Is there degeneration because of the instability or from a trauma? Is there also some hormone imbalance or deficiency in play? Because, of course, people with hypermobility, it's not like hypermobility is the only problem on the list. They have every other problem that any other human can have too. So we have to consider everything that's involved. Could there be some autoimmune condition, which we know is more frequent, or mast cell, which we know is more frequent in those with hypermobility, or endometriosis, adenomyosis, which, again, also more common, we think, in those with hypermobility, hernia, interstitial cystitis, things like that. Is there any primary neurologic issue, like small fiber neuropathy, neuroproliferative stabilidynia, And then, of course, the vascular stuff that I mentioned before. So like when I'm seeing a patient, I'm not just thinking about the hypermobility and like everything on this prior screen that we went through before related to the hypermobility pain, but we're also thinking about how that plays into the bigger picture of anything and everything else that may also be going on with this same patient. And then, of course, we have to identify how all of these things interrelate, because usually there's a trickle-down effect. And usually it's at least 3 layers deep. And so we start to look for patterns. We look for constellations, and we want to make sense of these things because that's going to lead us to the core issue. And ultimately, we have to treat the core issue, even if the trickle-down effects have become their own independent issues. We still have to find the primary. So I'll just give you a few examples here. So if the hip is a primary issue, there's often tension on the psoas. Tension on the psoas can put tension on the lumbar plexus or the genitofemoral nerve, which can then cause leg pain or mimic a hernia. I just had a patient today who has hip impingement, who has testicular pain, had hernias repaired, didn't fix the testicular pain. We do an inguinal canal block, numbs the testicle, but doesn't take away the testicular pain. How does this happen? Presumably the psoas, because the psoas is guarding the hip. The psoas puts tension on the genitofemoral nerve, which goes to the testicle. When we do the hernia block, it's downstream from this entrapment. So it will numb the structure, but not stop the pain, if that makes sense. So we have to try and make sense of all these. Obturator internus guarding, pudendal neuralgia, piriformis guarding, sciatica, ilium rotation, sacrospinous ligament tightening, pudendal neuralgia, adductor longus insertion strain of the pubic census, genital pain. That's all just from the hip. And there's more. This is not exhaustive. With hernias, it will cause hip pain. Just had a patient yesterday who was convinced that his hip was acting up. I examine him. It's hernia. He had a hernia surgery. He thought that was done. I'm like, nope, this is your hernia. We block the hernia. It takes it away. He's like, well, I thought that was my hip. I'm like, no, that's not your hip. Now you can feel what's left because your hip is not numb. So any pain that you're having in the hip, we can feel that now, and you can help distinguish that. Visceral pain with sensitization, interstitial cystitis type symptoms can happen with hernias. And then, of course, you can get acnes, abdominal cutaneous nerve entrapment syndrome. A lot of these things will cause abdominal wall muscle guarding reactions, which will cause acnes. Same thing kind of happens in the pelvic floor. We just don't have a nice acronym for it. Sacroiliac joint, tension at the sacrospinous sacrotuberous ligaments, pudendal neuralgia, pelvic floor guarding, pubic symphysis pain, sitting intolerance, lumbar disc herniations. Anytime there's a lumbar disc, 2 things. 1, it's innervated by the sympathetic nervous system, so it just feeds into the sensitization of the whole pelvic region. So lumbar disc pain can, reignite endo-type pain. So someone who had endometriosis, had it treated, it's all better, pelvic is calm, now herniates a lumbar disc. It's going to reignite that same sensitization pathway. So it may even present feeling like endo pain again, just because the nervous system's holding a grudge. So the lumbar disc itself can hurt, but then of course it can also irritate a nerve. Those nerves may go to the hip, they may go to the SI joint. It may amplify other pain because those nerves are irritated. And then finally, if there's neural tension from a lumbar disc, even if there's not an active disc pain or active radiculopathy, you can have leftover adhesions from a prior radiculopathy that allows there to be a point of tension on a nerve root that will need to be addressed in order for downstream pain to get better. So physical exam, how do we figure all of this out? We're really doing a very thorough physical exam to try and see what's going on. This is where I'm looking for those constellations of symptoms to try and understand what the primary issues are. We use imaging to the degree that it's helpful. Imaging really just gives us clues about your anatomy, and once we kind of see your anatomy and we know what's going on, we know what can happen. Even if it's not actively happening, even if it's not captured on that specific image, there are certain things that will give me clues that it is happening or was happening, and that factors into our problem-solving process. And of course, lab workup, mostly for autoimmune, just being thorough. And our general approach, which is still part of the workup process, because everything we do in terms of trialing different treatments either confirms or helps us adjust our understanding of what's going on in the body. So if there's sensitization, there's really three categories of sensitization, and you can have any or all of these three categories. One is neurologic sensitization, one is inflammatory rheumatologic sensitization, and then the other is psychological sensitization, like PTSD. And we want to sort of suss out which of those are in play, because anytime there's sensitization, we want to treat that first. The analogy here is if there's something on fire and the flames are so big that you can't actually see what's burning, we have to knock down the flames first. The flames are that sensitization. We want to get that under control, and then we can see more clearly what was driving it, because that's ultimately what we have to treat. So get the sensitization under control, then it will be more obvious. Is it a hernia? Is it a disc herniation? Is it the hip? What is it? So there's a few different ways: oral medications, IV infusions, sympathetic blocks. These are the ways we deal with neurologic sensitization. If it's autoimmune sensitization, we might do a course of steroid, we might do a course of an anti-inflammatory. And of course, if it's psychological sensitization, lots of biofeedback and ketamine therapy, talk therapy. There's a lot of pathways we have for this. And of course, pain psychology is essential. So get the sensitization under control, see if we can identify the primary structures driving the sensitization, and then we have to rule those in or out. So we will do diagnostic injections where the point of the injection is just to turn off pain from a structure, just to see if it's the source. And it's not meant to treat, but sometimes we'll often combine either steroid or regenerative medicine with that diagnostic block to see if we also get a secondary therapeutic effect. These are all things we talk through during the process, but just know we're looking to cover as many bases as possible with any intervention we do. And anything we do at this stage, again, it's iterative. We're trying to understand what's going on. We're trying to establish the flow, the cause and effect relationships, the cascade of symptoms. And the only way we can do that is by interrupting one of these structures by turning it off, or by treating something, just so we establish what role it has. And sometimes we do this and something will flare. And while we don't want to cause flares, it is a data point and it does give us more information. So it helps us know which direction to go. I'll give you a good example. With hypermobility, if we want to confirm that a joint being hypermobile is the source of pain, the sacroiliac joint is a great example. So SI joint pain with sitting puts tension on the sacrospinous ligament, tension on the pudendal nerve, pudendal neuralgia with sitting due to the sacroiliac joint. That's my hypothesis. If I want to test it, I have to stabilize the sacroiliac joint. So I could give the patient a sacroiliac belt, and if that's helpful, fantastic. But that's not a long-term treatment. That's just sort of proof of concept. Or I can inject the joint and fill it with fluid. If I fill the sacroiliac joint with fluid, then it becomes temporarily stabilized until the body absorbs that fluid. That will also give us proof of concept. At the same time, I might use prolotherapy with dextrose to try to tighten it and also get a therapeutic effect. If the patient responds well, fantastic. That's what we want. If they flare, there's a reason. And I have to figure out what that reason is. Might there be an underlying mast cell activation syndrome? Is there an autoimmune process? By stabilizing the SI joint, did we in turn irritate something else? Did we unmask the hip, for example? That will sometimes happen too. If the SI joint is being overused to stabilize the hip, and we take away the ability of the SI joint to be overused, then the hip will no longer be stabilized as much by the SI joint. We might unmask primary hip pain where there was actually no hip pain before, which is great, because then we know we actually need to stabilize the hip, and the hip is the reason the SI joint is hypermobile or being overused, which is the reason why there's tension on the sacrospinous ligament and the pudendal nerve is being aggravated. So there's 4 steps down that pathway, right? So that's the role of diagnostic procedures, and that's why it's a journey. And understanding the journey, going into the journey, is important, because it's rare that we understand everything fully the first time around. It's a little bit of a process. Sometimes we get lucky. Sometimes patients declare themselves with a very obvious and clear constellation that we've seen 100 times. And then we can say, great, this looks familiar. I'm pretty sure, I think I know what's going on. Let's try this and confirm it. But even then, you never know until you know. So once we've established that, we can move forward with treatment. The role of medications is really to keep you comfortable. And I explain to patients there are two pathways we go down as we start working together. One is getting you comfortable so that you can enjoy your life. And that's why you're seeing me, right? I'm a pain doctor. It's my job to make you feel better. So I have to do that, at least in part, right? So we want to get you comfortable. But we also want to figure out what's going on. And that's the second path is what's happening. Why is it happening? How did it come to happen? And how are we going to keep it from happening going into the future, right? Like, how are we going to reverse the course that this has gone down and redirect things so that you can enjoy the rest of your life? And through the process of us doing this, you will come to understand your body, what's going on, how that's happening, why those things happen, and what we can do about it. So each different treatment we try will either work or not work or have some reaction to. We feed that data point back into our bigger understanding of your body. And, all of this is education. So medications, we may use them to manage discomfort temporarily, stop an inflammatory process, reduce or reverse central sensitization. We may modulate the immune system, or we may use them for maintenance. It's not unreasonable to have some medications in play for a longer period of time just to keep things comfortable, or we may just revisit them for flares. Of course, physical modalities. So physical therapy is absolutely essential for hypermobility, and Pilates is basically my core religion for core religion. I didn't mean to make that pun, but there it is. It's my core religion. Pilates is my core religion. I'm going to put that on a t-shirt. So it's absolutely essential for not only building the core strength, but re-educating the muscles that have been being used to guard and compensate. We have to remind the body how it's supposed to be working, because at the point I'm seeing patients, there are all these compensatory behaviors using joints in ways they're not supposed to be used that we have to unlearn, stabilize the joint so you don't have to compensate, and then relearn how they're supposed to be used. And it's an educational process. It takes many months. And this is something Melanie's going to talk about a bit later because she specializes in this for EDS. So it's absolutely an essential role. Other things in physical modalities, sometimes we think about and biofeedback is kind of like a cross between pain psychology and physical modalities, but biofeedback is basically where you can listen to the muscle activity in different muscles, and you can recognize and learn how to control tension in certain muscles. It's really a good self-awareness technique. We will work with chiropractors for hypermobility. We'll work with acupuncturists. All of these things have to be done, in my opinion, with a team-based approach, because there has to be a larger understanding of what's happening, why it's happening, how it came to happen, what are we treating, why are we treating it this way, what are our goals for that treatment, what is the expected outcome, and if something doesn't go as expected, what are we doing? And that's my job. That's why I'm here. All right, pain psychology. The important thing I want to say about pain psychology is it's not like normal talk therapy. Yes, these pain psychologists have a doctorate. They are psychologists. They can do normal talk therapy, but they also did an additional year fellowship in pain psychology. And their specialty is really knowing the nuances of pain, how it affects one's life, the feelings of guilt and resentment and anger that have to be processed, the anxiety that comes around getting better, and the fear that comes around getting better. There's a lot of very special niche issues with pain. There's PTSD and medical PTSD associated with pain, and they're very familiar and they know how to parse all of that. But separately, they are coaches. They know about the journey of diagnosis, treatment, and maintenance, the three phases of the pain journey. And they help coach patients who may have been going through this, but may not be optimally using the system, on how to best engage with their doctors, on how to best keep notes, how to keep a pain diary, how to really take ownership and control of the pain journey themselves, because that's the only way forward. And that's, again, why I'm an educator above all else. Each patient has to learn how their body works, why, how, what, all of that has to be understood as much as possible, and I'm here to help them figure that out. And then the pain psychologist helps them integrate that information and make choices about their body, choices about their life with that information in mind. All right. I'm going to gloss over this because you've probably heard enough from me at this point. We want to move on. Know that we have a ton of treatment options. The the core treatment for hypermobility is regenerative medicine from my book, because the main issue with hypermobility is the ligaments, the connective tissue, are too stretchy, and we need them to be stronger and less stretchy. And we can do that using regenerative medicine techniques like prolotherapy, platelet-rich plasma, sometimes bone marrow. It really depends on the structure, what's injured, how it's injured, why it's injured, how we're going to keep it from getting re-injured. It's really looking at all of these things, putting it together, and choosing the correct treatment for the correct structure in the correct order. And that's what my job is, to help you figure that out and to educate you on the options so you can make the best choice for yourself. All right, that is me. Thank you very much.